In the spring semester, what we do is start with the most common contrast exams, and we're going to start with GI, and then we're going to do GU and biliary. After that, the rest of the semester is all about head work, skulls, things like that. So this particular PowerPoint is 250 slides long and growing. So I'm not going to do this in a single setting. I'm going to break this up into individual sections. So what we're going to do is first talk about chapter 17, which is chapter 12 in Bontrager's, if you happen to be using the Bontrager's. And what I'm going to do is do an overview of the upper GI portion of the alimentary tract, and then we'll do esophagram or studies of the esophagus, followed by the upper GI, which is a study of the stomach, followed by the small bowel series, and then we'll get into the lower GI tract. So this recording is just going to be about the top of the alimentary tract, which is going to be the esophagus, stomach, and duodenum, and just the overview, the anatomy, and some preparation for exam types that you might run into for those. So the alimentary tract is just a musculomembranous tube that goes from the mouth to all the way through the stomach, through the small intestine, through the large intestine, and out to the rectum and the anus. My mouse is really, really sensitive, so I'm going to use up and down arrows. So it looks like this. So if you can imagine everything that food has to go through to get from your lips until it's processed and expelled from your body, that is your alimentary tract. We also have accessory organs. So we have direct organs of digestion, that is your alimentary tract. And then you've got, or your alimentary canal, and then you've got accessory organs, which would be your salivary glands, your pancreas, liver, and gallbladder. But there are other textbooks that will include the teeth and the tongue and accessory organs of digestion. So you might want to hang on to that all the way through the registry in case there is something on the registry about the teeth and tongue being what portion of the digestive system would they be. That would be an accessory organ of digestion. So esophagus is just a long muscular tube, and it only really has one purpose, and that is to send food from the epiglottis all the way down into the stomach. So it lies mainly at the mid-sagittal plane. We're going to take a look at how it does deviate in a couple of different places, especially at the lower end, right before it goes through the diaphragm into the stomach. But for the most part, it lies at the mid-sagittal plane. Or it originates at C6, which is where the epiglottis is. It is posterior to the airway, and how you remember that is if you've ever seen a patient with a trach, the trach comes straight out of the front of their neck and it goes directly into the airway. So it does not have to push the esophagus out of the way. The esophagus is behind the airway. So it passes through the diaphragm at T10, joins the stomach at the esophagastric junction at T11, and the expanded terminal end of it is what we refer to as the cardiac antrum. Now, sometimes we have patients who have reflux where we've got some gastric juice that comes back up into the esophagus from the stomach, and what we call that in a lot of cases heartburn. So make that word association between the expanded end and the very distal portion of the esophagus and heartburn with your cardiac antrum. So the esophagus from a lateral view looks like this. So we've got the airway here, and then you've got the pharynx down to the epiglottis, where you've got a division between the airway and the esophagus, and then the esophagus is just anterior to the spinal cord. From a frontal view, so this will be front to back, what you've got in this aortic arch here. What you have then is the esophagus has to make a little bit of a turn around the aortic arch. And if you look down towards the bottom, it makes a deviation towards the patient's left-hand side. And that is right before it goes through the diaphragm and into the abdominal cavity so that it can join with the with the stomach. So that's your dilation of the esophagus. That's where your cardiac antrum is. So, and this is just superior to inferior view. This doesn't really add anything. It's just for your, visual. So the stomach is just a dilated sac, uh, and it is collapsible. And where it collapses, it folds, and that's what we refer to as a rugae. And we've got four parts to our stomach. That would be the cardia, which is the upper portion where the cardiac antrum meets up with the top of the stomach. That's cardia. And then the very top is what we refer to as the fundus. Then we've got the body, and the distal portion, the lower portion, is what we refer to as the pyloric portion. So it looks like this. So what we have up here is the fundus. Cardiac notch is where the stomach comes down, and then we've got the fundus that extends up beyond that. Cardiac antrum again is the distal portion of the esophagus. Cardia. We've got two curvatures. Anywhere in anatomy that you see something that's so specific as to say something like lesser, then you're going to have something that's also referred to as greater. Last semester we talked about the trochanters, for example, trochanters in the hip. You've in the proximal portion of the femur, you had a lesser trochanter, you've got a greater trochanter. Well, this is a lesser trochanter on the medial side, or I'm sorry, lesser curvature on the medial side. And it's lesser because it's smaller, it's shorter, as opposed to the greater curvature on the lateral side. So you have fundus, you have body, lesser curvature, greater curvature, cardia, cardiac antrum, cardiac notch, all at the pretty much at the distal portion of the esophagus. And then you've got the pyloric portion. You got the pyloric canal. You got a pyloric sphincter that controls the flow of food and liquid from the stomach into the proximal portion of the small intestine, which is what we call the duodenum. You may hear it referred to as the duodenum. So the stomach, again, the cardiac or the cardia is the area around the esophageal opening. The fundus is the very top of the stomach. The body is located between the top and the bottom. That um, has your greater and lesser curvatures on it. And then you've got the pyloric portion, and we've already talked about all this other stuff. So the entrance and exit are controlled by those sphincters. The cardiac orifice is the opening between the esophagus and the stomach, and then the pyloric orifice is what controls the release of the fluids into the duodenum. So you can have strictures at either one of those two. So at the cardiac orifice or the cardiac sphincter, what you may have is because of reflux, you might have a narrowing where food is having a hard time getting into the stomach. And what that leads to in a lot of cases is the expansion of the rest of the esophagus. So that's what we refer to as Barrett's esophagus. In the next section, we'll take a look at that. But you also have pyloric stenosis as well. And stenosis just means a narrowing. So pyloric stenosis sometimes is a congenital condition where a baby is born with a pyloric stenosis. And how we diagnose that or suspect, it's not a full diagnosis until we get an image of it, but how we suspect that the patient may have pyloric stenosis is if the baby starts to nurse and they take in some milk and the colostrum and it settles in the stomach, but it doesn't really pass through. It might settle there and it might spoil, and then the baby projectile vomits. That's a good indication that the patient has pyloric stenosis. So stenosis of the pyloric sphincter just means narrowing of the pyloric sphincter where the food can't get through, or in that case, the milk and the colostrum can't get through. So again, that's what it looks like. So the stomach, the position of the stomach is greatly affected by body habitus, and also it lies in the abdominal cavity in kind of a specific way that I'll talk about here in a bit. But as far as body habitus goes, it tends to be more high and horizontal in hypersthenic patients, and then in asthenic patients, it tends to be more elongated. It dips all the way down into the pelvic cavity in some cases. so that it's a very elongated J shape. With your hypersthenic patients, it might not really resemble a J, but in all other body habiti, it will look like some sort of J. And in a asthenic patient, it will be a very elongated J that dips all the way down into the pelvic cavity. So the functions of the stomach are a couple of things. One is food storage, but it does start the process of digestion, and it does that both mechanically and chemically. So you've got stomach acids, enzymes, and other things that help to break down the chemicals, but it also kind of churns the food, and it creates what we refer to as chyme. So in our imaging, what we have to consider is a number of different things. So gastrointestinal transit just refers to how quickly something clears. We'll talk about that a little bit more in depth. So we have to consider how quickly it gets to the stomach, how quickly the contrast gets from the stomach into the small intestine, and how long it takes to get through the small intestine. We have to consider our procedure and our order of procedures. So sometimes you'll do multiple procedures. You may do an esophagram, uh, upper GI, and a small bowel follow through all at the same time. So you have to consider your order of exam, and it might be a little bit surprising to you the way that we order exams. So sometimes we may do a upper GI, small bowel follow through, and a barium enema all in the same day. And again, it might surprise you the order of operation there. We have to consider our contrast media and what type of contrast we're going to use. We have to consider our preparation of the examination room and making sure that we have everything available that we're going to need. Your exposure time, you have to consider that as well because you've got peristalsis going on, causing what could be motion on your image. You have to consider radiation protection. Always consider radiation protection. And then again, your order of operation when you have multiple exam types. So gastrointestinal transit, you've got your peristalsis, and certain things can affect your peristalsis. So peristalsis, all that is contractions. It's kind of like where you've got. Imagine you're at an event where somebody makes the balloon animals. Peristalsis could be analogous to the clown or whoever it is that's making the balloon animals, blowing a little bit of air into those long cylindrical shaped balloons and then grabbing the balloon and pushing the air to a different portion of that balloon. So that's kind of how peristalsis works is you've got contractions on all sides of the gastrointestinal system that kind of pushes it through. But it can be affected by body position. So if the patient's upright or if they're laying on the right hand side, then it's going to be greater. So in a lot of cases, if we're doing an upper GI with a small bowel follow through, what your technologist may do is have the patient either sit upright in a chair, or if they can't sit upright in a chair, or if they're more comfortable, they may have the patient lay on their right hand side. There's nothing really magical about that. It's just sheer gravity. If you look at the way the stomach is oriented and where the different parts are, if you fill the stomach up with contrast and you stand the patient up, then naturally there's going to be more pressure on that pyloric sphincter and it's going to push the contrast on through the patient. Likewise, if the patient's laying on their left-hand side, what that's going to do is it's going to put this entire greater curvature up, which is going to put the entire lesser curvature with the pyloric sphincter and the pyloric canal down. So again, we've got a greater pressure at the pyloric sphincter. Gravity is one way that peristalsis moves through. And you can again think of that most of the time whenever you drink fluid, you don't want to be laying flat on your back. You want to get up a little bit. If you're laying flat on your back, you have a tendency to choke on the contrast or on whatever it is that you're drinking. So it's greater, peristalsis is greater in those two positions. So you got 3 to 4 waves per minute. Average emptying time for the stomach is 2 to 3 hours, depending on what you put in it. Average transit to the ileocecal valve, which is the very end of the small intestine and the beginning of the large intestine, is likewise 2 to 3 hours. So our contrast media, we've got basically two things. We've got barium sulfate, and then we have some sort of water soluble iodinated contrast media. And depending on the exam type that we're doing, and also the patient's their expected outcomes and what we expect the diagnosis to be, our contrast media is going to change. For example, if we have a patient that we're doing an upper GI on because they suspect that the patient has a bleeding ulcer. Um, the bleeding ulcer may actually be a perforated ulcer so that there's a cavity or a hole going from the stomach or the small intestine even into the abdominal cavity. And in that case, we don't want to give the patient barium. And the reason for that is because the barium will get down or out into the abdominal cavity and you just can't get it out without going in and washing it out. It'll be there forever, as opposed to the iodinated contrast, the body will absorb and excrete through the kidneys. So we'll get rid of that with the water soluble iodinated contrast, but we can't with barium. Likewise, if the patient is suspected of having a history of aspiration, we don't want to give the patient the iodinated contrast. We want to give them barium. So the contrast media is going to change with the patient condition in a lot of cases. In a lot of cases, strictly the patient condition. So they both have benefits. The iodinated contrast goes through the GI tract a whole lot faster than what barium does. So it clears in about 1 to 2 hours. The problem with it is that it's not good for double contrast. It doesn't adhere to the wall of the esophagus, small intestine, stomach, or any of that very well. It does give us a decent exam of, for solid column for the stomach, duodenum, and large intestine, but we can't get air contrast. On the flip side of that, again, if the patient has a bleed or a possible perforation, it's much safer for the patient. Uh, Again, with the barium, you might get a toxic event if it leaks out into the peritoneum, and your best possible outcome is that the barium is going to be inside of their abdominal cavity potentially forever. Also, if patients suspected of needing surgery to follow the exam, then we're going to go with iodinated contrast as well. One other thing, I kind of skipped over this. Sometimes you'll see technologists add um, some iodinated contrast to the barium just to kind of give it a little boost. It clears through the GI tract in a whole lot shorter period of time than what barium does. It acts kind of like a laxative, so sometimes your technologist will add it to try to make it move through a little bit faster. So your preparation of the examination room, you want to have everything available before the patient gets there. So the things that you need to consider would be, if you're doing an esophagram, make sure the footboard's on the bed, put it onto the bed, and then shake it and make sure that it's locked in real well. Shoulder supports could potentially be an issue for uh, esophagams and upper GIs where we may put the patient into Trendelenburg position to demonstrate a hiatal hernia. So we'll talk about that again when we get into upper GI and esophagram. We'll take a look at what a hiatal hernia is. So we'll want to make sure that we check our image receptors, make sure we have proper image receptors, make sure our fluoroscopy is working properly. Make sure you have the proper types of contrast. Make sure that you have something available for the patient if they get sick. Contrast does not taste good. I recommend my students to taste both types of contrast, providing they're not allergic to the contents. If you have an iodine allergy, you don't want to taste the iodinated contrast, but the contrasts don't taste good. Don't tell your patient it's not all that bad. It's every bit that bad, especially the iodinated contrast. The barium tastes like flavored chalk. The iodinated contrast has a very metallic taste to it. So imagine, uh, a tin can, only they try to flavor it with lemon. So it's really not very good. So um, you want to describe the contrast to them. Don't lie to your patient, but don't try to talk them out of drinking it either. Provide them, if at all possible, with a large straw so that they can bypass most of their tongue. Make sure that you introduce the person who's going to be running fluoroscopy to the patient and let them know that the room is going to be darkened so that they can see the images better on the TV screen that they're going to be looking at. So, one issue that we have is because of peristalsis and because of where the barium might be going and what exam type we're looking at, exposure time can be an issue, especially on things like esophagram. So the contrast is going to go from the um, the mouth to the stomach pretty quickly. So we have to have very short exposure time. Um, but even when it's not, we're still going to have to deal with peristalsis. So once we put the contrast into the patient, we have constant motion. So we want to use as short of exposure time as possible to eliminate some of that. So again, with the patient upright, what we're going to be looking at is your exposure time of zero point 0.1 seconds or less. Uh, Two ways we accomplish that. One is that we utilize a very high kVp because we're using barium most of the time in an esophagram, not to be confused with modified barium swallow, but an esophagram, we're probably going to be using um, barium. So we can use very high kVp, use a high MA station, it should give us a short exposure time. So we can affect how quickly, though, that it passes. So if we have a patient take in a big deep breath and then swallow, then it passes a little bit slower than if we just have the patient drink as quickly as possible. So uh, deglutition just means swallowing. It's just the fancy word for swallowing. So in the stomach, it's not going to move quite as fast. So our exposure time doesn't need to be quite as quick, but you're probably not going to change your settings on your machine. This is just FYI. Our exposure time can be a little bit longer, but no longer than zero point 0.5 seconds. So peristalsis again moves in waves, and it is often referred to as motility, and it greatly affects how long the studies are going to last. So your studies of the upper GI and esophagram are going to be over pretty quick. But if you're doing an upper GI small bowel follow through, then you're going to get into exam types that may take hours on end. So your radiation protection, uh, you know, the PowerPoint came with this shield pediatric patients, patients of reproductive age, and it's not universally accepted yet that we don't utilize shielding any longer, but uh, it's going in that direction. So just to understand that by the time you take the registry, the recommendation universally may be not to use any kind of shielding. But what you always should do is use close collimation. Remember, you've got a number of different things at your disposal for radiation protection. Technical factors, high KVP, low MA, or low mass exposures are better for the patient. But also, if you can expose as little of the anatomy as possible to the direct central ray, then your radiation dose goes down. So your technical factors and your close collimation truly are your radiation protection. If your hospital and your doctor are still shielding patients, then you can certainly try to educate and try to move them away from that if that becomes the accepted norm. But you should always follow your hospital protocols. So, what might you see on a test for, and all the way through the registry on the general anatomy of the upper GI system? So, you got to be familiar with terminology, your deglutition, your motility, things like that. So you have to be familiar with the terminology, know where the alimentary canal begins. That would be at your epiglottis around C6, and it ends at the anus. So make sure that you can identify the anatomy from descriptions and drawings, the functions of the esophagus, what it does, and that is just to convey the I'll start to say contrast, but the food contrast from the mouth all the way down into the stomach. The functions of the stomach would be to begin the process of chemical digestion. Really, mechanical digestion began with your teeth, but in the alimentary canal, the mechanical begins in the stomach. So know when to use each type of contrast, know your technical considerations. That will be your KVP. You want to use high KVP, especially with barium. You want to use 100, 110 KVP with barium. Make sure that you understand your time. You want to keep your time as short as possible. Because of the peristalsis and the constant motion, you want to keep it as low as possible. Your radiation protection will be your good technical factors and your close collimation. You might hang on to the concept for your individual test, hang on to the concept of shielding in case you're still being taught that. But I'm pretty sure that the position statement for the AORT is that shielding is no longer a thing. And then what body positions are best for GI transit. So keeping all that stuff in mind all the way through the registry and in your test, that's probably what your test questions are going to come at you as.